I am here actually to tell you that the concept of surgery nowadays is to preserve the organ. So organ preservation is the key factor for doing the surgery. But earlier what we do see, we know the kidney cancer is essentially a surgical disease. It can offer the cure when it was confined to the kidney after removal of the whole kidney. But my talk is not to remove the whole kidney. My talk is how to keep maximum kidney preserved after removing the kidney tumor. So I have no potential disclosure to be disclosed, and I am definitely acknowledged to my mentors, both home and abroad, and my patients. So these are the scopes. I will flow on the talks on the nephrometry score, the philosophy of the tumor enucleation study, which is conducted in my center, then some case series, evidence in literature, whether these were supported or not, and then take home message. These are the scope of talk which I will run through. We know there are three types of organ preservation surgery in the kidney besides the radical nephrectomy. These are the partial nephrectomy, these are the nephron surgery, these are the tumor enucleation. I will talk on the tumor enucleation. So what is tumor enucleation? Before I go to the tumor enucleation, let's see the partial nephrectomy. You can remove the part of the kidney with the tumor. And what is the nephron sparing surgery? Minimum 0.5 millimeter remove normal healthy kidney tissue along with the tumor. But what is TE? It is remove only the tumor with its pseudo capsule. So the tumor pseudo capsule is a histological basis of a dense fibrous tissue which give a protection to invade the tumor cell to the normal parenchyma. This is the basic histology for the enucleation of the renal tumor in case of it. But the literature said if the tumor is 4 centimeter or non-clear cell histology, an incomplete pseudocapsule that could have invaded the pseudocapsule. Otherwise, it was intact when it was in a clear cell variety. So in our study, what we see, surgery is the standard of care in the kidney cancer. But traditionally removal of the whole kidney was done. With better delineation of 3D image, preservation of kidney cancer is possible. Concept of nephron sparing surgery was popular since 2006. Tumor enucleation is a new paradigm shift in the kidney cancer. So we studied 54 cases on last 2 years. Is a cross-sectional study. We included the renal score 9 and below. Renal score was done in the CT scan of triphasic CT scan of the KUV, and that was radiological assessment and putting the score for assessment of the complexity of the removal of the tumor. These are the surgical variables: renal score, histology, margin, blood loss, cold ischemic time, duration of surgery, 30 days, Cleveland Indo postoperative complication, and local recurrence in the long term was assessed. The median age was 47 years, sex male preponderance, histology, BMI was 24, margins, cold ischemic time, hospital stay was assessed. Cold ischemic time average was 25 minutes, blood loss was 350 ml, and margin 5 was positive out of 54. And we see the histology. The clear cell was 89%, papillary was 8%, and the chromophobe was 3%. So 3D model is very, very important to take out the lesion, not hampering the kidney. So before subjecting the patient for the surgery, we have to read out the 3D image very nicely so that you can get the clear picture in relation to the renal hilum, renal vessel, and the veins. So these are the 3D images which was leaks in the internet. So I cannot show these unilateral and bilateral kidney. And I will show some few case series here. In case 1, you can see that the tumor actually playing in a place where the renal artery and renal vein was encasing. So this patient went in many places, and they were planned for the radical nephrectomy. and the patient was actually unwilling to remove his kidney. So this patient was subjected for the partial enucleation. After displaying all the vessels, we give an incision in the avascular plane, and we find out the capsulated tumor. We take out the tumor, keeping the kidney intact. In case 2, this was also a hilar tumor. We went in the renal hilum. We clamp the vessels, ice putting over there by cold ischemia, take out the cancer, rhinorrhaphy was done, and preserving the kidney was possible. In case 3, it was double primary duodenal tail cancer, as well as the cancer in the lower pole of the kidney, and we do in the same sitting by the tumor enucleation in the renal part. In this case, it was in endophytic and partly exophytic. It was removed by tumor enucleation. And this is a stage 4 CKD patient having diabetes and hypertension, medical CKD. With that, the kidney was preserved, but removing the part of the kidney. And this tumor was exclusively endophytic. It remained inside the kidney. So the Pearl Wester technique is said that you just bivalve the kidney, like the nephrolithotomy was done for the complex staghorn, and then you dissect the tumor inside, and you can take out the tumor, preserving the kidney intact. So video is not running here. And this is, you can see the kidney was bisected and tumor inside, and we can see the surrounding dissection of the tumor, and tumor was taken out. So what actually literature says, the tumor which diameter less than 6 centimeter, they have especially a radial vascular pattern. It can enucleate very nicely. And TE is effective and safe treatment for T1 renal cancer, and T appears to have acceptable early oncological outcome and significantly lower positive margin in case of tumor enucleation. So in conclusion, T is a viable option when clinical situation warrant for preserve the renal function. T is oncologically safe. The take-away message is T is not replacing the partial or the nephron sparing. Image reading is key for enucleating mass. 3D model takes upper hand. Suitable in tumor in single kidney. Multiple bilateral tumor can be dealt with and can preserve trifecta. Thank you for patient sharing.